Good morning, good afternoon, good evening. It's Dr. DeShavo. And I had a request to review some x-rays. So I have put a very basic x-ray review together. And please realize that, we spend years studying x-rays. Radiologists spend their whole career. So this is a very, very basic introduction to go over very basic ways to review x-rays. So I'm just going to focus on three views. Cervical, thoracic, lumbar. Thoracic, you could also say chest view. It depends on what you're focusing on. And a real basic way to review these things is ABCs. Alignment, bone, cartilage, soft tissue. Oh, I didn't realize that was a video. So if we pull up the cervical, I just want a picture for now. Okay, cervical x-ray. The better you know the bony anatomy or any anatomy, the better you'll be able to read the x-rays. So ABCs, alignment, bone, cartilage, soft tissue. So this is a side view of the cervical spine. There's actually several views here. In cervical spine, I learned, I've heard students recently reference it as severe trauma x-ray series. There's some sort of series, I forget, there's like a buzzword and everything. I learned it as Davis series. So you come in with somebody who has had whiplash, severe whiplash, or any type of whiplash that we feel warrants an x-ray. You put them through what I learned as a Davis series. It might be called something different now. You would do a lateral view. So if you can imagine, this is the jaw. This is the cervical vertebra. Those are the body of the vertebra. These are the spinous processes back here. So the patient's facing this way. So that'd be a lateral view. PA or AP view depends on which way the x-rays go through that patient. So if the patient is facing the x-ray machine, their back is against the bucky. The bucky is what we used to call the bucky. Once again, I have old terms, but is what controls or contains the film. If the x-rays go from the anterior to the posterior of the student's an AP view. If you want the chest film, you want the lungs closest to the film, you would do what's called a PA view. Okay, so depends on which way the x-rays pass through. This is part of that cervical series where you look in to see, this is C2. Okay, and if you look at the bony anatomy of C1, C2, atlas and axis, they fit snug together. And this is the dens of C2. They can actually be fractured upon severe trauma. Okay, so if you take an x-ray with the mouth open, you can see C1, whoops, that should be a little bit cleaner, sitting right around C2, and the dens, you have to look the anatomy of that up, sits right up into C1. Well, if you fracture during a severe acceleration, deceleration accident, you can fracture that dens right off. You can also take a look at that dens with patients who have, say, rheumatoid. That articulation between C1, C2 can actually get lax, and you can get a separation of C1, C2, very mild, but still, me as a chiropractor, I wouldn't go cracking their neck if they have instability between C1, C2. So once again, if that doesn't make sense, pause it, go look at that anatomy, and then come back. And then that's another lateral view down there. If you continue with that trauma series, you would actually then also have oblique views. So you can make sure the alignment of the vertebra are good that way. And you could look to see where the space is where the vertebral, cervical nerves come out and make sure that they're patent and open. So I know I'm giving you a ton of information. I'm probably blowing right over, but let's go back to the basics. ABCs, alignment. You want to make sure, if you know normal cervical alignment, that these vertebrae sit right on top of each other, and you actually have one continuous line that should be continuous. That's just my hand moving. I'm not trying to follow it. Alignment should be good. If you have a cervical fracture, you could have one of these vertebrae that have moved out of place. You look at the PA or the AP view. Generally, this is going to be, I believe, AP in the cervical spine. Those will be aligned. The alignment of C1 and C2, okay? You want to make sure alignment is good. And in order to know good alignment, you need to know the anatomy. But, my advice to you is you got your phone. If you're going into a cervical x-ray review or thoracic, you don't remember, pull up normal anatomy first. Look at a normal anatomy x-ray review. There's a million of them out there. I know because I've just been pulling up examples to show you. And you can grab that normal anatomy first before you go in. So alignment. Okay. Bones. You want to make sure that for bones, these vertebrae are all square, for example. There are some patients that get compression in these vertebrae, and the vertebra might be compressed and smaller. Once again, the better you know normal anatomy, if you look at this x-ray and you have a compressed vertebra, you'd be like, whoa, that doesn't look right. These spinous processes, you want to make sure these are all intact. So you want to look at all the bones. Soft tissue. We could have, so with x-rays, the denser the material, the whiter it will be, the less dense, the darker it will be. So for example, we have air here. Okay. So this will be the trachea. You want to make sure the trachea is midline and dark. You want to make sure there's nothing in it and then it hasn't deviated. I actually had a patient who had a deviated trachea. She had a large fatty tumor that was pushing it aside. Thank God it was benign. She had it taken out. She was fine. So alignments of the bones, alignments, I guess, of soft tissue. I had a patient who had abdominal calcification of his aorta. So you want to make sure that that aorta in that calcification, where is the alignment of it? Where is it going? Okay, so alignment of the bones and, not really soft tissues, but sort of derivation of that alignment. Bones, cartilage. Okay, let me clear this. You cannot diagnose a herniated disc or soft tissue issues really from an x-ray. You really need to have that MRI or the CAT scan, but you could see the quote unquote like shadows of them, right? So you could see this is a pretty good space in here. That's getting a little bit decreased, maybe some issues. Okay, and I'll show you on other x-rays. You could get a decrease of that cartilaginous space. Okay. So cartilage. And then soft tissue. I had a patient, let me see, hold on a second. Let's see. I had a patient who, unfortunately didn't listen to me about this. And you could see right here. He, came in, bad, gosh, I don't remember by now. It was almost 20 years ago. Lumbar, whatever. I caught part of the aorta and I could see this calcification. Okay. Actually, I do think it was expansile on him. It's above, 4 millimeters was the last that I knew. I'm sorry, centimeters. 4 centimeters was the guideline. If they start to get above 4 centimeters, that is indicative of surgical intervention, depending, of course, on the patient, because it is, as you know, pretty invasive surgery. Anyway, he came in and he did indeed have that abdominal calcification with expansile lesion. So, me as a chiropractor, if I had just looked at his lumbar spine, I would have missed that. I always did the ABCs: alignment, bone, cartilage, soft tissue. That's the last time I say it, I'll promise. So I looked at his soft tissues in his abdomen. I showed it to him. I said, and I'm not telling you names, so I'm not divulging confidentiality. You need to go and get this checked. And he didn't, and he died from it. So the lesson there is I thoroughly documented my conversation with him. I talked to him again. I think I even called him again, and tried to convince him to do that. But that was a good lesson for me to always look at that soft tissue and to always document. He died, I think, a year later, unfortunately. So, I mean, his family could have come back on me if they had known, but I documented. I tried. I even, I'm like, let's call your doctor right now. But anyway, so unfortunately that happened. But once again, x-rays are not our primary go-to for soft tissue things. However, there are things that you can find on x-rays that will help to hopefully guide patients in the right direction. Okay, so bear with me. So cervical we went over. There's the airway. Once again, you always want to make sure that you look at the airway with the cervical. And then moving on to thoracic. So you could get a chest radiography. You can also get a thoracic. You see how you can actually narrow down the field, the x-ray field, if you want to minimize x-ray exposure. X-ray exposure at this point, I mean, they're so fast. I think somebody told me you get more exposure to radiation flying than you do with x-rays, but you can narrow it down. I personally would rather see the whole field because once again, you're taking a chest film. What if that patient, God forbid, has some sort of tumor over here? You're doing it for the little bit of radiation, you may as well get the field. And then if you think there's something serious in the thoracic spine and you want to get it a little more specific, because narrowing that field also will give you a more specific x-ray for that thoracic spine, you can narrow it down then. But let's look at the chest film first. You want to, once again, alignment, make sure that the thoracic spine is aligned, that all the ribs look clear and good. You could look at the clavicle. Oops, sorry, this would be the clavicle. This would be the scapula here with the spine and the scapula. Sorry about the drawing. So bones, you want to look at the bones. You can't see them as well on this x-ray. Cartilage you can't see as well. You see that a little bit more on the lateral chest film or thoracic. Soft tissue you could definitely see. You want to look at the lung fields. You want to make sure the trachea looks patent and open, and look at the soft tissues. When I look at this, your diaphragm will be here. There's some sort of bubble here, which is kind of interesting. They don't make a note of that. Maybe just a gas bubble, perhaps. Okay, but anyway, you want to go through and look at all of those. You can look at the bronchi here and make sure those look okay. And of course the lung fields, which I'm sure you're very familiar with looking through. And if we close that out, you could see the vertebra better because we've narrowed down the x-rays to a more narrow specific area. They have the vertebra counted down for you. Okay. And you could actually see, oh, this is a great one. Normally I can't see this as well. The tracheal bifurcation. So you can see where the trachea bifurcates, which means it's splitting, which goes down to the, hold on, let me look really quickly. I'm double checking. I'm pretty sure that's right. And that's left, which brings up a good point because the reason I'm hesitating is I believe this is the heart here. I'm not seeing this very well. So the heart, of course, will go to the left side. So this would be left and this would be right. Quite often they'll also mark it. I'm sure you've seen that a million times where they'll have the R or the L that's metallic and you could see it going to one side. But this is really nice. You can see, let me erase this, trachea. You can see the bifurcation. You can see the right primary bronchus is more up and down. So that's why if you inhale something, it's more prone to go that way. And then you can see the left splitting off there. And then you can see the vertebra very nicely. So you could look at the size and the shape of the vertebra, go through your ABCs. you know, there's a little bit of soft tissue. I always want to look, even though we can't see all the way out into the lungs. But that's a nice breakdown there. You can even see the transverse processes, which are the little arms that stick out to the sides. Okay. And then there's pedicles. And, you know, once again, I'm not getting into all the specifics, but there are certain areas that are more prone to fracture. You can fracture those pedicles. That's why I think they have those marked. And then you can't see the cartilage. You can see the discs here. So you can't see them super, super clear, but you can see them from step to step. So if you're looking at from one level to the next, you would see it get slightly thicker as it moves down, and you don't see any on here. You know, I'm just looking very quickly that look a lot thinner than other ones. If you saw one, that one is not thinner, but if you saw one that's a lot thinner than the others, they might have a herniation there. Herniations in the thoracic spine are much more infrequent. We don't see it quite as often. Okay, so I can't, hold on a second, I've got to move the screen down a little bit here. Huh, I don't know why. Give me just a second here, I'm sorry. My drawing tool is in the way. Oh, there we go. Okay. I couldn't close out the windows. So this is going into the lumbar spine now. Okay. This is very straight. Just so you know, it's part of the reason why I pulled this one up. So if we look ABCs, alignment, you're supposed to have a nice lumbar curve. She has a very straight curve, or he. And then you should see it curving back. Okay, those are the normal curves that you'll see on that lateral film, as opposed to the A to P or P to A. Generally, if you're doing the spine, you want the spine up against the bucky where the x-ray film is. That should be straight. If we get a curve on that A to P film, it would be indicative of a scoliosis. So alignment. Bones. You could see here, I'm going to erase this. This vertebra is not quite as square. This one's pretty nice, healthy vertebra. And that's the body in the front. Should be about squarish. If you look down here, and once again, I'll erase this once I explain it. You're starting to get a bone spur here. I exaggerated that. And here, you're definitely getting a bone spur here and here. And then this vertebra is not shaped as well as those nice normal square ones. And it's because this person doesn't have normal alignment of the lumbar spine. You know, the S shape in normal spines makes it almost like a spring. So it's a little more resilient, and there's some almost spring back of the spine. When it's on, you know, in the normal curvature, creating that nice in curve on the low back and the nice out curve on the thoracic spine. This patient with such a straight spine, excuse me, is causing a little abnormal pressure on this low back. So they're getting bone spurs, also known as osteophytes. You're getting a little bit more compression on this vertebra because it's getting more pressure than it should be. And interestingly enough, they've lost a little bone in this one, and that may be they have a secondary condition. It could also be, oh, this is definitely a female because of this. Do you know what this is? Yeah, you know what it is. It's going to be the hooks on their bras. You really should take that off. Always should have all metal removed. Okay, which I'm sure you know. But there's a little loss of bone density here, which could be something else going on. I would actually absolutely send her out for a CAT scan just to make God forbid that there isn't anything weird going on. That's enough of a difference if you look at that loss of bone. That's probably not. This would probably be compressed, but I'm just thinking I would absolutely send her out for further studies. But anyway, there's abnormal pressure on these vertebrae because you don't have that nice springy curvature. So alignment, bones, cartilage, there is a little bit of disc space loss there, probably a little bit more even up here. Cartilage and then soft tissue. This is just gas that's over there. Okay, when it gets really, really dark or black, it's gas. Now, if we think, and then you also have to look at the SI joints, see if those have any wear and tear, bone spurs on them. When you start to get an excess or loss of bone density, like we saw here, okay, and this actually looks a little bit whiter than this side. Extra bone is being deposited there, not a huge amount. Let me take a look at it again. There might be a little extra here. There's abnormal wear and tear, and so your body deposits a little extra bone there to help support it. It's a natural response. It's an over-exaggeration, what's called Wolff's Law, WLLF''S law. So, and that's what happens with bone spurs too. The body knows there's some instability, so it's going to deposit a little excess or extra bone on those bones there to create more stability. It's an abnormal response to abnormal stresses on the body. So, with her, I'd probably, hold on a second. I knew I'd pulled one up. I'd send her out for, and this is an MRI. So, that top one, so the MRI, they'll do a lateral view and also a transverse view. And the patient doesn't move, right? They stay in the same place. It depends on how they shoot the, shoot through them. So this top one here, this top one would be as if I cut myself into a top and bottom and we're looking down and in. And it'll show the herniation, but this is very hard to see. So I'm going to pop down to this view. Excuse me. And this is a side view of the spine. So this is the sacrum. This is the lumbar spine. So this is L5. This is what we call S1. The sacrum has 5 fused vertebrae. So they basically start, I shouldn't say vertebra, I should say bones. They start as separate in the fetal, excuse me, I'm so sorry, excuse me. In the fetal skeleton, the fetal skeleton starts as cartilaginous structure. So in the sacrum, it's cartilage and there's 5 fusion centers to it in the sacrum. They fuse together into one hard bone, but you could actually look on a real sacrum and see there's 5 separate parts to it. So anyway, so this would be S1. Some radiologists will say that, L5 S1 juncture. That's why. So looking at that, so here's the vertebral bodies, here's the spinous processes, and in between them, in that round hole, if you look down inside of a vertebra, is the spinal cord. And on this was a really great MRI. There's a huge herniation. I'll erase it in just a second. You can see it almost goes completely across that space that the spinal cord comes through. And that should be open. And you should see this white spinal cord coming down in that white open area, but it's not. This person has an absolutely huge herniation. And if we actually move down, I am not sure because it's hard to see. The definition is not great on this one. So I'm not sure if this is the same person or not. I'm trying to compare them. To me, oh, that's a little bit better. I had to tilt my screen a little bit. No, it's not the same person. I think this is a different MRI below. But nonetheless, herniation at the same area. And I liked showing you this one because this one is so big here. We can actually get them where they break off and they end up in the floating around in the spinal, where the spinal cord is, which is not good. So if somebody has like a massive herniation and a massive amount of pain, then all of a sudden it goes away, it could be what's called a sequestered disc, where it actually breaks off and floats away, which you can imagine might get stuck somewhere else. So, so that's like total basics of MRI. And this is bad, obviously. And you could see there's that same, they're pointing at that same presentation that almost looks like the same picture. You know, the one thing before I log off, and once again, there's my very, very basic, oh, there's a good, here. So you can see right here, negative MRI, and you can see how much more space the spinal cord has. So, that's a bad thing. And the herniations can go in the spinal cord, but they could also go to the lumbar spine, spinal nerves as they come out. So it can cause all sorts of problems. If you get that herniation into the spinal cord, you could get more like cauda presentations, you know, genital numbness, as opposed to one-sided leg pain. So just as a sidebar. I think that brings us to the end of my review. I mean, this is a very basic. Like I said, I mean, I studied radiology for years. But, you know, basic introductory. Wow. We got to look at that really quick before we. So, extraspinal findings. I figured that it almost looks like a uterus. I don't know if you saw that. Here we go. Retroverted uterus. Huh, thought it was a uterus. So that's so cool. I'm so glad I got a chance to show this to you. I could do this all day long. So the uterus usually, as you know, is anteverted and it hangs over the bladder. And that's why so many women have problems with bladder control when they get pregnant, right? Because it presses down as well as extending all the way up to the xiphoid process. This is a retroverted uterus. So it's pushing that sacrum back. That's pretty cool. Well, not cool. I feel bad for this person. You understand what I mean. It's a pretty cool educational tool. So thank you so much for listening. This is very informal. I hope this helps and you enjoy it. And take care and let me know if you have any questions. Have a great day.